So we are starting the second session. I will call Dr. Harinder Singh for ocular trauma stitch in time saves 9.
Yes.
He will present in place of Dr. Indraman Rastogi, who had to leave.
Second. Yes.
So Dr. Harinder Singh from
Today we'll discuss about ocular trauma, stitch time save 9s. Let's see. So stitch in time saves 9s means simply just like a stitch in the time in paint saves it for more than 1, 2 or 3 months. Ocular trauma approximately 7% of all the body trauma and 10 to 15% in ophthalmology pathologies. Globally, 1.6 million people are blind due to ocular trauma, 2.3 million are bilaterally blind. Approximately 90% of the ocular injury can be prevented. In one North Indian study says 82.3% non-occupational trauma constituted 23.9% case of sports related and rest are 89.3 case has mechanical injuries. These are the various mode of trauma, just like 24% wood injury, 20% metallic object injury, like this. Now we'll look at ocular injury. Most common ocular injury worldwide, monocular vision impairment and blindness. As per WHO, 55 million people experience serious ocular trauma. The average incidence around in world 3.5 per 1 lakh population, and more than 2 lakh cases occur every year. These are main people which are affected, mainly men and boys, during playing, during outside activities like this. This is the Brigham classification, which is the most accepted in the ocular trauma. It shows two type of injury: open globe and closed globe. In closed globe injuries, contusion and lamellar lacerations, and in open globe, rupture and lacerations. In ocular traumas, early diagnosis and appropriate treatment by ophthalmologists save the eye. Means if we diagnose the patient earlier and treat appropriately, give if there is scleral injury, we suture the wound. If there is corneal injury, we suture. Then save the eyes and improve in the prognosis. Helps in preserve the vision. Now these are the various form of injury. Foreign body injury, it might be blunt trauma, penetrating trauma, chemical and radiation injury. Chemical and radiation injury has separated treatment course, and foreign body blunt trauma and different course of management. Now ocular trauma is a race against time, means it is a time how early you manage, how early you intervene. Requires a detailed history, clinical examination and radiological investigation for salvages. How we assess? Proper history should be detailed by possible time and nature of injury, which type of injury, blunt, missile, foreign body retained, chemical, etc. Past ocular history, visual acuity, if you have a patient having a recorded visual acuity, rule out any life-threatening injuries, rule out any globe-threatening injuries, examine both eyes, detail examine from lid to cornea, sclera, just like anterior chamber to till retina. Documentation is must. Photograph documentation is must. Then we plan for repair. Any structure of eye can be involved, just like we see in previous slide, from anterior to posterior, lid to retina. Any tissue can be involved. Depending on the involvement, damage is there. If not treated, structural deformity, blindness can occur. Now we'll look for principle of management. What are the principles? Basically, we have to restore the injury, restore surgical integrity and preserve visual acuity, repair major trauma under general anesthesia or local anesthesia, whichever possible. Aim of the closure a close as far as possible except in case of expulsive hemorrhages. Try to identify the extent of laceration and perforation. Try to reappropriate the corneal tissue injury, ocular injury with proper suturing technique. If there is challenging to assess the lens damage, posterior capsule integrity, and therefore plan to manage the subsequent surgery. Just we look in the previous presentation how to manage the foreign body, intraocular foreign body. What are the imaging techniques? X-ray, CT, MRI, USG, OCT. These are the techniques we will plan according the injury, which investigation is better, depending on the involvement of tissue also. Prognosis determined by time taken for the start of treatment, degree of injury, type of eye involved injury, and prophylactic measure better than treatment. It is always says कि prevention is better than cure. So prophylactic management is better than treatment. Now we'll look for grading for chemical injury. This is also known as Roper-Hill's classification. Grade 1, 2, 3, 4. In grade 1, no damage to cornea and limbus. In grade 2, cornea is hazy, but iris details are visible. Limbal ischemia is there, which is less than 1/3. In grade 3, cornea is hazy, no iris details seen. Limbal ischemia is 1/3 to 1/2. In grade 4, very poor prognosis, cornea is opaque, limbal ischemia is there, more than half, 50%. Now we'll look for medical treatment. Corpus irrigation is first. If there is corneal injury, corneal perforating wound, first we will wash and mat the iris, or we will look for if we can restore it or we can cut out the iris. To restore the normal pH, topical steroid to reduce inflammation, topical and systemic ascorbic acid, topical system citric acid, cycloplegics, topical tetracycline to inhibit glycolysis. Basically citric acid is in tablet, na topical. Role of safety education is if vision is lost, one become handicapped. So we will look in these cases. Getting a suitable job is difficult. Ocular eye injury is preventable. Onus on clinician to educate patient eye safety. Eye safety is more important than to treat. We will educate the workers or outside workers, wood worker, handlers, like you should prevent this injury by wearing gloves, helmet proper. Primary eye care is having great role. Role of safety education include patient education, worker on eye safety, such as wearing face helmets and safety goggles when working with splashing liquid or flying debris. Mock drill in chemical injuries must. Safety lecture, first aid training is must. Kids sports person to wear safety goggles. Strict protocol should be followed. Now take home message is this: the measurement depends on time of injury, the need of surgical intervention, and final visual outcome depends on the mode of trauma, time of presentation, extent of ocular damage, time of surgical intervention, and post-operative care of the patient. Thank you.
Thank you, Dr. Harinder. Next is Dr. Ranjit Singh Dhaliwal from Nabha, Punjab. He will speak on manual SICS, surgery for all season and regions. Dr. Shri Vidya is there? Okay. Dr. Bhavani Rana.
Good afternoon, everybody. I'm again here with this presentation. You could literally call it marketing SICS. I'm Ranjit Dhaliwal from Nabha. It's got a very small population, 95,000, surrounded by a vast rural hinterland, connected to Delhi by just 2 trains, saving grace is an international airport within 90 kilometers of Nabha, which I think would be better than the circumstances in Delhi. This presentation, as all my presentations, are dedicated to Vikram. This too is dedicated to him. The title of this presentation is Manual SICS, a surgery for all seasons, a surgery for all reasons, but I have added this why before it. Ophthalmology today, as it was 35 years back when I first made this presentation, is still on its cutting edge. Better, not necessarily the finest equipment in association with absolute dedication to ophthalmology to provide personalized care to even such patients is the necessity. The aim is to provide dedicated and professional care. Improvisation and indigenization brings the latest technology to the multitudes of masses of our country at a reasonable cost. A modern setup at the primary level can boast of quality services and does not cost a fortune, I would say, in the present day circumstances. Now, why manual SICS? India, a land of vast disparities, presents still presents at any given time a linear panorama from ancient couching to modern phaco and femto. Manual SICS fits in at all levels, a surgery from primary to the most advanced level of patient care. Cataract surgery is no longer a simple rehabilitative procedure, it's an extremely precise refractive surgery, goal being emmetropia, though not exactly these days. Manual SICS is easy, I would say, provides all the advantages of a small incision with few complications. I call it a hazard-free, but people tell me it's more difficult to master than phaco. Smoother, it has a smoother and easier learning curve, rather no learning curve for one already into ECCE and implant surgery. It is in fact a revolutionary technique, ideal for teaching institutes, government tertiary centers, and or wherever finance is a constraint. It has arguably the same objective and results as phacoemulsification, presumably not a single absolute contraindication. Charm of SICS is its simplicity. It's a no additional cost option and little extra investment is required. A hard black cataract, any surgeon's nightmare, is just a single step procedure removing such a nucleus in SICS. Nucleus can be delivered with a fish hook made of 26 gauge needle and irrigating vectis alone by the sandwich technique or by the hydro or visco expression technique. Cases of cataract coexisting with most of these comorbidities have all been taken up for manual SICS at our center at one time or the other. It is a must for phaco surgeons for times when they have to convert due to phaco machine failure, posterior capsular rupture, zonular dialysis, hard black or brown cataract, or having used too much phaco energy. The phaco machine and the paraphernalia that goes with its instrumentation, sterilization, repair and replacement are a costly luxury for entry-level small clinics. Though we were able to buy this particular machine later on, but still our phaco rate was only 5%. Rest was all SICS. And my most controversial slide, phaco machine out of order. The ordeal begins. Sales and marketing team, efficient, slick and polished. After sales service department, I would call even in the biggest hall, callous, indifferent and unreasonable. The less said, the better. Phaco surgery has a hazardous and steep learning curve and arguably is a time-consuming procedure for people other than the masters. This word arguably was put here in this slide because of my friend Dinesh Verma. He said many people would think otherwise. Common problems faced with in cataract surgery can all be tackled with manual SICS. A superiorly placed trabeculectomy bleb, a large hair knot on the head as supported by the holy men in India. Traumatic cataract and pre-existing PC defects are no contraindications. This was a difficult case, deep set eye with a narrow palpebral fissure. We performed canthotomy and went ahead with manual SICS. And I started doing temporal very early, advantages being the external scratch incision may be placed right on the limbus instead of going through the sclera. By opting for the temporal approach, we are able to bypass the eyebrow in a deep set eye, and the bridal rectus suture is not necessary. Irrigating fluid flows down through the lateral canthus, so no chances of backflow of the fluids. In oblique astigmatism, I would just move the tunnel superiorly or inferiorly, placing it tangential to the steep meridian. As I used to move inferiorly, Vikram started went over to the superionasal side also. Superiotemporal approach is also used in cases having no astigmatism. This is a case of one of our cases of temporal SICS the day after. In manual SICS, I would say the final results are arguably again extremely good in the learning period, but fascinating once the technique is mastered. Thank you for your patience.
Thank you, sir. Thank you, Dr. Ranjit. I am calling now Dr. Rahul Deshpande, demand generation of capacity building and improving performance in high volume eye hospital. Okay, sir.
Thank you, sir, for giving me the opportunity to present earlier. And I'm thankful for the opportunity because I have a flight to catch at about 1:30. Yeah. Uh, yeah. So, good afternoon and welcome you all for this today's talk about the demand generation and the capacity building. Demand generation and capacity building. Like demand, first of all, the first half is the demand generation. Now, whenever you start a eye hospital or where you have an established practice, now you have some competitors in your vicinity and then really you want to have your show, you want to run your show. So that is basically you have to generate the demand. Like the patient should come to your hospital, patient should seek treatment and then they should regularly visit hospital. So how to generate this demand? This is also for the newcomers or for the established practitioners who are getting competitors in their nearby area. So that is first reaching the unreached and second approach is the reaching the reached. Now in the first is reaching the unreached. Now you have to reach where you have not reached. So by active camp screening, fixed facility services like the vision centers in the vicinity and outreach services and referrals. So you should get good referrals. So this technique is the reaching the outreach, then unreached. Then of course, as you all know, the cataract is the main cause of the problem with the vision loss. Then apart from that, glaucoma, diabetic retinopathy, refractive errors, and we have to think beyond the cataract. Now, whenever you are doing a service, cataracts everyone is doing, but your hospital, what specialty they are doing, so that is also quite demanding. Like we in Pune, there was no oncology department and all medical college also they refused the managing such patients. But then we started recently with the department of the ocular oncology and we are getting good referrals from all the hospitals. So that is the reaching the unreached and where services are really needed. Of course, cataract and all other services that you have to take care of. Then reaching the unreached, again the corporate tie-ups are important, insurance tie-ups are also very important. Certain schemes like the government and the non-government organizational schemes you have to do, industrial tie-ups and tie-ups with other sectors like school, colleges, banks, housing societies and clubs to get the patients, to get the clients. So that is very important. Then the development with the certain NGOs like CBM, Orbis, HelpAge, and the documentation, the report generation, vision building workshop, then that sort of a hard work is also important. Now marketing. Now there are certain norms laid by the government and the other NMCs and also directly we cannot do open marketing, but then indirectly we have the conventional marketing strategies, digital marketing and mass media marketing. So whenever you want to market, you don't market about the name of the surgeon or the facility, but then what new has happened, what new has come, what new machine has come, that you can advertise and you can market. So then no one can take objection, neither your contemporaries who are there in the hospital, they will have any objection to that. So that is a different or that sort of a strategy you have to imply as far as marketing is concerned. So these are all about the marketing strategies, social media marketing platforms, they are easily available and mass media is also available. Now the second thing is about the reaching the reached. Reaching the reached means the already a patient who has come to your hospital. Now again you want to attract that same client, his or her relatives, the patient from their nearby area. So that is the reaching the reached. So for that you have to have your good ambience, satisfaction of the internal customer, good infrastructure and sophisticated equipments. That is all. So reaching the reached is again a good clinical care you have to give, of course. Then the rational diagnostic procedures. It is not that you have got a OCT and unnecessarily you keep on doing OCT for all cases. So after certain time people will realize that this test is not really needed. They want to make use of the equipment and make money or want to get the money and cash. So you are using it. So that sort of thing should not be there in clinical practice. That will have a bad name and the customer who has come to your hospital, he will never come to your hospital because they will think that you are unnecessarily doing the investigations. Then the state-of-art surgical equipment, management of complications that has to be done and adequate follow-up is also required to get the client who has already come to your hospital. Then of course the other modalities like counseling, convincing, personal touch to patient and empathy is also very important factors in reaching the reached patient. So already a client who has come to hospital, to attract him, these all strategies you have to employ in order to increase your private practice. Then certain opportunities are there like daycare attendance, inpatient and their attendance, waiting area has to be taken care of, market new product strategies, patient advocacy, patients group discussion is also very important with the patients, that from patient's perspective, what all things you have to incorporate in your practice, or how you can change your routine model. So that is also important, because patient can give you a good insight that you can think accordingly from your side that yeah, this is correct, but then patient will tell, oh no, that is not correct, you have to do like that. So you have to welcome such thoughts from the patients. Then second part of my talk is about the capacity building. Now once, this is a short presentation about the capacity building. Once now you have built the clients, now how to increase your capacity. Don't keep on adding many doctors to your organization. Like we in our hospital, we do about 200 surgeries per day and see 800 patients per day. But it is not that every doctor who is coming and showing his biodata we are admitting, or any nursing staff is coming, we are admitting to hospital or giving employment. But the capacity, the existing doctor or existing staff which is there, you try to get maximum work done from them. So that is the main aim of the capacity building. So capacity building is basically joining the basic skills, learning attitude, as well as the additional work like providing support, then the multi-purpose workers and personality development. The capacity building, again, the good infrastructure, clinical, educational skills transfer and research. Then in capacity building, resource is also very, very important. So whatever the employment you are taking, or how the person, his attitude towards work, his approach, or whether he has come to hospital just to get his salary, or really he wants to do more work, and his performance, his capabilities, his identification, whether he is a unique feature to get more patients to your hospital. So all those things, they have to be taken in consideration in capacity building. Then performance measurement, target versus achievement, return on investment. Don't invest unnecessarily on the hi-fi equipments and all. So again, think for return on investment. And then resource strategies, then the effectiveness, the non-functional, functional, and economical, the blend of financial and non-financial things you have to make for giving adequate results to patients. Then again, in your medical stores, purchase, stock consumption, monthly maintenance forecasting, all these strategies you have to develop in order to save money and give maximum this thing to the patient. And human resources, the staff, motivation, commitment, satisfaction, and active participation. So to make the human resource in a running state and to make him more happy, you have to employ. So I think I am running of time. So certain awareness, like become a part of the All India Ophthalmological Society, then Vision 2020, collaboration, help, and all you have to employ in that. So in nutshell, the demand generation is wherever you want to get more patients, and capacity building is whatever existing staff you have to motivate them so that that staff can do maximum work for you, and the adequate utilization of all equipments you have to think. Thank you very much, and thank you, sir, for giving me the opportunity.
Thank you, Dr. Saab. Very nice talk. Shri Vidya, she will talk about over-the-counter eye drops. इसके बाद मेरा सर ये मेरा थोड़ा बोल देना.
So good afternoon everyone. My topic is over-the-counter eye drops. The term over-the-counter eye drops does not have much significance in India, since many of the drugs are available without prescription on demand by patients at the pharmacy. Even though there are many laws and regulations prohibiting the practice of dispensing of prescription drops without prescription, the practice is still rampant. Almost every prescription drug is available without a doctor's prescription all over the country. In India, laws which regulate this are not as stringently as imposed as in other countries such as United States. So these are the different complaints with which the patients visit a pharmacy, like redness, itching, pain, watering, foreign body sensation, and trauma. These are the most popular over-the-counter eye drops, like antibiotic and steroid combinations, antibiotics, steroids, sometimes decongestants, and also lubricants. Decongestants, antihistamines, and lubricants are the eye drops which have been approved for the OTC use. Recently, even chloramphenicol has been approved. Other available ocular medications are prescription eye drops. So here are a few cases which we have seen in our center. The first case is, it is a 42 years female who has come to us with eye pain and loss of vision in both the eyes from 2 days. She has been using steroid and antibiotic drops from 6 months, which is obtained from a pharmacist without any checkup. On the day of examination, the best corrected visual acuity was 6 by 60 in both the eyes with IOP of 38 and 40 millimeters of mercury. When we have done a slit lamp examination, there was corneal haze and the angles were closed. A second case is of again a 42 years female with blurring of vision in left eye from 2 months. She has been using steroid eye drops twice daily from about a year, and her best corrected visual acuity was 2 by 60. And on slit lamp examination, we found posterior subcapsular cataract. Then we have a 34 years male who has come to us with pain, redness and discharge in right eye since 2 months. He has been using steroid eye drops and antibiotics with the advice of a pharmacist, and when we have examined, there was herpetic keratitis. In the last case, it's 46 years male with severe pain, redness in left eye since 1 month. He has used some drops suggested by the pharmacist. Then the pain and redness has resolved, but he slowly developed some gradual vision loss. On slit lamp examination, we could see anterior uveitis with vitritis. So these are the differential diagnoses for a acute red eye presentation, which we encounter regularly in our practice. We have studied in about 1 to 1.5 months that in about 100 patients who have complained with redness, their first visit was to pharmacy is about 46%, and the complication rate was 22%. About 100 patients in whom they have visited with watering, 63% of them, and the complication rate was only 2%. Whereas 100 patients with itching and foreign body sensation, their first visit was to pharmacy is about 58%, and the complication rate is 12%. And with pain, 54% of the patients first visited a pharmacy, and the complication rate was about 24%. So as we know, the most common complications of corticosteroids, like steroid-induced glaucoma, cataract formations, delayed wound healing, and increased susceptibility to infections. But there are also certain complications with other types of OTC drugs, like antibiotics can have drug resistance, corneal and conjunctival toxicities, itching and dryness. Decongestants themselves can cause different forms of conjunctivitis. Lubricants sometimes can cause corneal and conjunctival toxicity, loss of natural tears, and may increase dryness. So the Pharmacy Act of 1948 regulates pharmacy practices in India. Pharmacists are expected to be careful and cautious while dispensing medicines to the consumers. They're expected to educate the customers about intake and effects of the drug. Unfortunately, in India, most of the chemists are themselves not knowledgeable enough to educate the consumers about OTC drugs. They neither insist on a prescription for a prescription drug nor question the customer about the need for a particular drug. So what are the motivating factors for this OTC usage? That is easy availability of wide range of prescription drugs without prescriptions, low medical literacy among the populations, advertising by the pharmacist, and desire to reduce the cost of healthcare. Many of them think if we go to the doctor, they'll suggest us some investigations and it is a waste of time and waste of money. So these are the different studies which have supported that we are not supposed to use the over-the-counter eye drops. In India, there was a study showing that 99.1% of the people lack knowledge about 2 types of ophthalmic preparations, that is prescription-only drugs. And they have reported about 3 cases of total vision loss. There are also similar studies in Saudi Arabia, and Suparkar and co-workers also describe different patterns of conjunctivitis by ophthalmic decongestants. There is also a study in Bengal saying that the habit of misusing steroid medications through self-medication, it can lead to complications in eyes. So what are we worried about? The most important thing is, yes, complication rate, glaucomas, maybe increased susceptibility to infections, and if you think commercially, even I have seen multiple patients who are saying that we went to a pharmacist, they have given us drops, the redness has reduced within 1 day. But you're giving us treatment since 1 week, but it is reducing slowly, not instantly. Maybe that person has described some phenylephrine plus tropicamide combination and there was blanching of the conjunctiva. So what should we do? One thing is awareness in the public and education to the pharmacist. Pharmacists themselves should be enough knowledgeable to educate the patients so that they don't give away the prescription drugs without prescription. Thank you.
Thank you, madam. Please come out with a YouTube video. 2 minutes YouTube video.
Sure, sir.
that one should not prescribe.
Thank you, doctor. Now I invite Dr. Narendra Neja for the talk for vaccination for doctors. Actually, maybe all get that HIV or HPSAG or SCV markers done for all our cataract and other surgery. So now what is more important is what vaccination should we have?
Thank you. Let us talk for our health now. एक मिनट बताना भैया ये नेक्स्ट करने के लिए कौन सा बटन नेक्स्ट करने के लिए So here I don't have any commercial interest. The trade names have been given only for the sake of convenience. So we are talking about vaccination for ourselves. Pneumococcal vaccines. Pneumococcal is one of the most prevalent bacteria among the persons who are admitted in ICUs, and they are the leading cause of death, and they are resistant to most of the antibiotics. There are two types of pneumococcal vaccines. One of them is called pneumococcal conjugate vaccines. Whenever the term conjugate is there, that means they are long-acting vaccines. They give cellular and herd immunity. And most of them, they are used only once in life for adults. In children, 3+1 doses are used in private setup and 2+1 doses in government setup. But for adults, only one dose is sufficient. There are 4 different types of PCVs. PCV 10 and 14, they are used only for children. 13 is available here in India, and 20 and 21, they are not available in India. 21 was introduced only 2-3 months ago. So we can get Prevnar 13. This is used both for adults as well as children. Normal people above the age of 50 years, they should go for a single dose of these vaccines. And if the person is below 50, but with immune suppression like chronic kidney disease, nephrotic syndrome, long-term steroid use, HIV, asthenia, then PCV 13 is given followed by 2 doses of PPSV 23 after 8 weeks and 5 years. If you are above 50 with these conditions, you should also go for this vaccine. Pneumococcal polysaccharide vaccine, also called PPSV 23. This is contain 23 different strains of this pneumococci. This is a weak vaccine. Immunity lasts 5 to 10 years. T-cell independent vaccine, no cellular immunity. 19 to 50 with comorbidities like asthma, heart disease, diabetes, chronic smokers, or living in cities like Delhi and Gurgaon where there is high pollution level, they should get one dose of these vaccines. And in person with immune suppression, this is given after PCV 13, 2 doses, and 1 dose is reserved for persons above the age of 65 years. Once the PCV 20 and 21 they become available, then there will be no need of this PPSV 23. Coming to flu and typhoid vaccines. Flu vaccine is inactivated tetravalent split variant vaccine. It is given yearly. This prevents swine flu also. All of us must get this vaccine yearly. Recently, Nasavac S4 nasal vaccine has been developed by Serum Institute of India. You can go for that also. Typhoid conjugate vaccines. All of us must get this vaccine. Though in the literature it may mention 6 months to 45 years, but you can go for it even if you are 60 years or 65 years or 70 years. This is one of the most cost-effective vaccines because you need to get only 1 dose in life. Both these vaccines, they are not in the national immunization schedule. So the children, they are not usually getting this vaccine. And dose of the vaccine is same for children as well as for adults. Coming to measles, mumps and rubella. This vaccine is very important for ophthalmologists also because we want to prevent congenital rubella syndrome. This is a live attenuated vaccine. Single dose should be given to young girls or in the preconception period, or marriageable girls, or just after marriage, and then pregnancy should not happen in the first month. But for other health workers, two doses should be given. Hepatitis A, there are two types of hepatitis A vaccine. This is also not available in the national immunization schedules. So the children, they usually do not get this vaccine. Killed vaccine, Havrix 1440, usually not available. So you can combine 2 vials of Havrix 720 and make it 1 dose. There is another vaccine called BioVac A, which is live vaccine, which is given subcutaneously. Here the dose is same for adults as well as children, that is 0.5 ml. If you are having some problem in the liver, you must go for this vaccination. Hepatitis B vaccine, 3 doses are given 0, 1 and 6 months. If you are not immunized in childhood, you should go for this vaccination. If you are above 50, you can go for a booster vaccination. If you are immunocompromised, go for IgG level check. If they are below 10, go for a booster. If they are 0, go for 3 doses of this vaccine. Chickenpox or varicella vaccine and zoster vaccine. They are viruses same, but the vaccines are different. Chickenpox or varicella vaccine is a live attenuated vaccine. 2 doses are given at 1 to 2 months interval. This vaccine is like rubella vaccine. This is important to prevent congenital rubella syndrome, because if in pregnancy chickenpox happens, then there are various congenital abnormalities, including in the eyes. Shingle or the zoster vaccine. This is to prevent herpes zoster in persons above the age of 50 years or those with weak immunities. 2 doses are given. This vaccine has become recently available, Shingrix. This is non-live vaccine, unlike Zostavax, which is a live vaccine. 2 doses are used. Tdap. Many of us may not have heard this name, Tdap. Tdap contains full doses of tetanus and reduced doses of acellular type of diphtheria vaccine, which can be used above the age of 7 years, and reduced dosage of diphtheria vaccines. So this vaccine should be taken every 10 years, and if one is not sure of earlier DPT vaccination, and second and third dose can be taken of TD. In pregnancy, at least 1 dose of this Tdap is must, even if the pregnancy happens next years. Rabies killed vaccine. Dogs are everywhere, so we should get this vaccine pre-exposure. Pre-exposure, 3 doses are given at 0, 7 and 21 days, and subsequently dog bite happens, 2 doses can be given at 0 and 3 days, and then there will be no need of antibodies. If you get class 3 bites, you are not given early vaccination, then you need to get antibodies also. Human papilloma virus vaccine. This is also called cancer preventing vaccines, because initially it was advertised for cervical cancer vaccines, but this prevents other cancer also, genital cancer, anal cancer, head and neck cancer, even conjunctival cancers, besides anal and genital warts. The Cervavac 4 vaccine has been developed by Serum Institute of India, and as soon as this announcement was made, the prices of the Gardasil 9 and Gardasil 4, they were markedly reduced. So please ensure that you get the vaccine at the rates mentioned here. 8500 for Gardasil 9. The distributor may supply you vaccine costing 11,000 rupees. So these are gender neutral vaccines. 9 to 14 years, or even up to the age of 9 to 14 years plus 11 months, 2 doses are given, and 15 to 26 years, 3 doses are given. In females above the age of 26, they can go for this vaccination, but after consultation, because they may have been exposed to some of the viruses earlier. In pregnancy, as I already told you, at least 1 dose of Tdap. Another dose of TD can follow, or it can be given before Tdap. Besides that, flu vaccine is given during pregnancy. So, coming to preconception period, we have to emphasize this. Around the age of 20 years, 25 years, marriageable girls or college-going girls, MMR vaccine to prevent congenital rubella syndrome, varicella vaccine or chickenpox to prevent congenital varicella syndrome, flu vaccine, typhoid conjugate vaccine, both hepatitis A and B, and human papillomavirus. Plus, if they are adults, besides this Tdap and zoster vaccine and pneumococcal vaccines. Special situation, yellow fever if you are traveling to Africa, South America, meningococcal vaccine during epidemics, or you want to study and go to Europe or USA, like to Scotland. Dr. Dinesh Verma is from Scotland. If one is going to there for long period, he should get this vaccine. And Japanese encephalitis in India in endemic areas only. Thank you very much. If you have any questions,
nice presentation.
you can ask.
I think it's a very nice presentation because as an ophthalmologist, we do not know about all these vaccination because we only know when we just are in our MBBS for your SPM, that the National Immunization Program. So it was a very good presentation. I'm having 2 or 3 questions. What about your influenza vaccine? The strain changes. So
One should go for this vaccination every year. Every year. There are 2 epidemics, one in July when monsoon comes, another in January. So every year 2 different vaccines, new vaccine they arrive.
Is there
whatever is latest, they are made, they written northern hemisphere, southern hemisphere, whichever is latest, one should go for that vaccination. And one can go for every 10 to 11 months.
So is there any difference between that such age group, maybe less than 50 or more than 50? There should be different schedule regarding this vaccination?
Schedule is same. If you are immunocompromised or low immunity, you should go for this vaccination. In children 1 to 5 years, this vaccine is a must. For above 5 years, if you are having comorbidities, then you should go for the vaccination. Or if you are repeatedly having episodes of common cold, then you should go for the vaccination.
And the other point is regarding the chicken pox, because when it occurs after 50 years, then I think it is a very devastating complication it has. So what do you advise regarding the chicken pox vaccine?
So now Shingrix vaccine that has become available last year since June. It costs about 11,000 rupees. You will get it for 9,000 rupees. You should go for 2 doses of this Shingrix vaccine. Earlier, about 2016 and 17, Dostavax vaccine has become available in India, made by MSD, but that was a live vaccine, so it could not be given to immunocompromised persons. This vaccine, just Shingrix, can be given to any person. If you get vaccine, can be given to any person. Even if a person has herpes zoster, after 2 months, he should go for this vaccination because the natural herpes zoster that will not give that much immunity. You should go for these 2 vaccines. He need not go for this vaccination, chickenpox vaccination. But once you reach an age of 50 years or you are immunocompromised, go for a Shingrix vaccination. That is different vaccine to prevent herpes zoster ophthalmicus. Similarly, as ophthalmologists, if you are getting patient of herpes zoster ophthalmicus, we should offer this chickenpox vaccination to all the contacts in the families. If they did not have chickenpox, if they are not immunized against chickenpox.
Okay. Now.
Yes, sir. England.
This was very useful. In the National Health Service all over UK, England, Scotland, for healthcare workers, these vaccines are a must. Most of the ones that you mentioned. And flu, every year they call you and you have to get it done. Otherwise, you won't be able to work. They're still doing COVID-19, which I haven't taken the booster yet. I've done all the full course. But the herpes zoster is now available, and they do 2 doses. But everything is free on the NHS. Here, obviously, the prices are a little bit of a deterrent, but I would still recommend people should get these done. It was a very good talk.
Yes, sir. All these vaccines, they are must for our health workers, our health staff, all our paramedical staff. Like the Tdap is must because we must not transmit infection.
Yes.
To small children, because these children up to the age of 2 years, 50% of the mortality is due to this whooping cough. They are caused during the first 2 months. So
and also to protect ourselves.
If you are going to become nana, nani, dada, dadi, if you are going to become a father, mother, you must get this Tdap vaccine.
Okay. And what about your take on the hepatitis C vaccine?
C vaccine is not available.
It is not available because now hepatitis C induced cirrhosis of liver is on the rise. It's very much on the rise, and that is the reason we are getting every patient of cataract,
vaccine available with
HIV, HBsAg and HCV done. HCV also, and that is the reason you have to get every patient for your cataract surgery, the
ट्रिपल एच
viral
करते हैं
marker.
तो इसीलिए इसमें हेपेटाइटिस बी सी और HIV करवाते हैं.
That is more important. Thank you, sir. It was a very good insight as an ophthalmologist for us also. Thank you very much. Now, next speaker is Dr. Vineet.
नहीं ये नहीं है.
अच्छा, okay, sir.
Dr. Bhavani Rana.
Yeah.
Dr. Bhavani Rana from Jammu. I suppose you are from Jammu? Yes. Can we have gender neutral medical fields?
Good afternoon, everyone, and thank you AIOS for providing me with the opportunity. I shall be it's not coming there. I shall be talking about, can we have a gender neutral medical field? So I start with a very cliched statement that women have proved themselves in every profession. Then I add one more cliche to it. There is still a gender bias in all walks of life, and medical field is not an exception to it. And this goes beyond the boundaries and beyond the borders. So in a developed country like UK, there are more CEOs named David or Dave than there are all women CEOs together. When we come to India, 50% of students joining the medical stream in India are females, which is a good sign. But unfortunately, only 1/3 of the postgraduate students are females. And if we do a shedding, the number gets skewed down when it comes to surgical branches like general surgery, ENT, and ophthalmology. And here, I am not talking about traditionally held female jobs like gynae and ops, which for centuries have been considered to be a female's responsibility. The Association of Surgeons of India has 32,000 members, but only 12.5% are female. When it comes to All India Ophthalmological Society, we have seen only 2 female presidents since its inception in 1930, and ophthalmology is a branch which has a huge amount of female representation. In India, there are only 18% women in leadership position, and most females are working as frontline workers. And also the ladies who take up surgical branches eventually settle for academic or research-based profiles rather than going into active clinical practice. That is probably because the ladies have to take care of the families also, which is traditionally considered to be their first and foremost duty. So starting from the residency days, a female surgeon has a very uphill task. When it comes to my story, well, ophthalmology is considered to be a refined branch, and anything that is refined is considered to be a female's calling, because we have been doing embroidery and knitting and needling since ages. However, the moment you enter into a stage where you are in a position of authority, the trouble starts. The subordinate staff, they are not very keen in taking orders. Junior colleagues take time to adjust to you, and they try to surpass and bypass you. We are grouped with the nursing staff. Here I do not mean any disrespect to them, but there is a mentality you can't see female in a position of authority. It is difficult to obtain a patient's trust. I once operated upon a patient, and the next day the lady, and she was a female patient, she said, "Doctor साहब आप लड़की थे ना, इसीलिए हम थोड़ा सा घबरा रहे थे." So surgery is associated with showmanship, strength, and flamboyance, and these things are easily associated with males and not with females. The higher ups, they are either condescending, and at times they are downright biased. It is simply like, yaar isko chodo, isko rehne do, give the work to some other male colleague. You have to break the glass ceiling, and many times you are not involved in the post-surgery camaraderie sessions. Complications at the hands of a female surgeon are discussed and dissected to shreds, and they are sometimes passed as anecdotes. Opinions and ideas are not given consideration, and when you start speaking loudly, they say, "She's very aggressive." Any kind of personal growth, it requires technical training, and more than that, it requires role models, mentorship, and support groups. Now, most of the females of my age have been mentored by male seniors, and we owe a lot to them. But if you have a female who is in a position of authority, the younger female surgeons will look up to her. They can understand that if she has reached this stage, in spite and despite of all the difficulties along the way, they can do the same. So it is very important to have examples. So what we need is, we need more representation and more women in positions of authority and decision making. So in short, what do we need? We need women leaders. And yes, women leaders who welcome females. Now why I emphasize this statement is, I am a senior colleague in my institute. So we get the postgraduate students. So my tendency is, I'll take the male postgraduate student and give my junior colleague the female postgraduate student. So there is a barrier in my mind also. Unless and until I'm able to get over this barrier in my own mind, how do I expect my male colleague to get over this barrier? Another point is, as a junior female surgeon, it is very important that you prove yourselves and you don't come every time that you have family issues, so you can't do this job. You have to compete in an open world and you have to do same amount of work as your male colleague is doing. So it is a both way, flow. Then only we can move forward. Excelling in surgical specialties is a very long journey, and if the surgeon is a lady, it is a difficult trek, just like a trek through the mountains. So I'm leaving you with photographs of 3 very inspiring ladies. One is Dr. Anandi Bai Joshi. She was probably the first female allopathic doctor from our country, and she died at a very young age of tuberculosis. Other is Dr. Elizabeth Blackwell. She is probably the first female surgeon and the first black surgeon actually. And then we have our Padma Shri, Dr. Padmaja. She is a burn survivor and herself a pioneer in burn treatment. So a wholesome growth needs a wholesome team, and a team can be wholesome only if it is all inclusive, it has representation from all the genders and at odd levels of hierarchy, not that the administration is in hands of one gender and the menial work is being done by the other gender. So we need equal representation at equal point, and then only we can flourish, and this gender world will just go out of this medical jargon. Thank you.
Thank you, Dr. Bhavani. मैडम ऑप्थेल्मोलॉजी में तो अब लेडीज़ ही ज़्यादा हैं, एटलीस्ट मैं देखता हूँ अपने यहाँ रोहतक के आसपास, तो वहाँ पे लड़के कम हैं, और डॉक्टर प्रियम कुछ कहना चाह रही हैं.
Society, male surgeon dominated society. So the thing is, as you have rightly pointed out, that we have to work hard. Definitely, we should not have any bias in our minds, and then we have to prove ourselves. Yes, this extra effort, this extra step we need to take, we have to take, because we have to prove ourselves amongst no grudges, no bias against anyone, but we have to prove us amongst the male surgeons. Like where I work, in that place also, if you have a female patient, the female patients would also ask, like, "Aankh kaun banayega?" Okay, so if they come to know ki, they will be ki yes, male banayega to achhi banayega. If it's a female, to they tend to stop and think. But then you have to break those things. You have to break the ceiling. Like how? So this thing happened at my workplace as well. Now you have to give an answer. But you have to give an answer that has to be in a way that provides some support to, yes, you are good at your things. So I was facing these issues at my workplace. So what did I do? I recently operated on both the eyes of my father. And yes, so this is the answer. So my patients now I have, you can go ahead with whatever you want. You can't remove this deeply ingrained bias in them ki male surgeons are better. But then to prove yourself, first you have to prove yourself to yourself. Okay, that yes, I am able to do it. Females definitely have a stronger emotional part. Yes, that may pull them back sometimes. But then we need to overcome that. We have to cross that barrier, and once we prove it to ourselves, we can prove it to others. Then I think at least there will be no need of proving then.
Actually, so I have a distinct point in my department. So there are 2-3 females and we have 1 male. So sometimes I feel that the subordinate staff will ask him whether we should do it, and if he says yes, then they will tell the other staff, "Sir bol chuke hain, isliye kar lijiye." So what I do is I call all of them together, make them sit together, and then I ask everyone's opinion. And whatever the point, whichever the majority suggests, we go with it. One thing, and I always give support to all my staff, whether it's a male staff, the female staff, I like to move them up so that they feel they are wanted and they are equally important. So, you know, we have also to remove those barriers, then only we can
Right, the change begins with us.
with us only.
Right.
Thank you, madam. Thank you. We'll now call the next speaker,
Change nahi chahiye ki we dominate over
Dr.
each
Dinesh
other.
Verma
We
from
just
Goa
want
and
equality.
Scotland.
Yeah.
Please, sir, come.
That is
Okay.
important.
Thank you,
Just
Dr.
want to
Bhavani.
make one point. I agree with both of you totally. And this was the situation about 20 years ago in UK. But they have really changed. Now women are in leadership positions, in surgical specialties and ophthalmologies. There definitely it is in majority. I don't think in India is still in majority. Women there are in majority. The only thing I don't agree with your
Priyam Vada.
assertion that to prove yourself you have to operate on your parent. I would never do that. It is unethical in UK. You should not operate on your relatives. I know it's very common in India. People do that, and there are two reasons for that. One is if supposing something goes wrong, for the patient there is no comeback. You know, he's not going to sue your daughter or your son. And the other one is your emotional attachment, because we are taught to be objective when you're treating a patient, so that decision making, emotion doesn't come into it. And that part you can never do with a parent. I would never operate on any close relative. That's
Thank you, sir. Please
Yes,
come forward
sir,
for your
the-
presentation, sir.
There are two sides.
We have three
I would like
speakers
to
left.
say. There are two sides to this thing.
If
I
time is
agree
there,
to
we
the
can discuss
emotional
again,
part,
sir.
but then we have to overcome that part. Yes, definitely.
So actually,
So just one quick comment, because you know, having a wife also as a doctor, not just just limited to the field of ophthalmology, I feel females have already breached that thing, in at least in the metros. The only thing that the problem which I see, you know, being the other half of my wife, is that where there's licensing for the referral, it is where there are things they really cannot breach that barrier. So that is the only thing that is left to be breached. Rest, I think things have already been taken care of.
Thank
you
you,
mean the networking?
Yeah,
We are not
networking,
very
yeah.
good at networking.
Thank you,
Not,
Asaf.
not good, not good.
Not good, but
we could just we have, like, you know, easier for males in that, because we can have a sip of
I
drink
said
and
those post-surgical sessions.
Sir, please, no more discussion. Dr. Dinesh, please come for your presentation. Discussion during lunchtime. Dr. Anil, you are Dr. Anil? Ankur.
Yeah, start off. Is he going to control from there? Yeah. Thank you very much for inviting me, the organizers. I'm going to be very quick. So the topic that I have chosen today is of special interest, and I do have commercial interest because it's the device I've been developing for the last 15 years. So the topic is democratizing eye care in Indian villages and small towns. How does artificial intelligence and the virtual reality simulation helps in making these screening devices, diagnostic portable devices, as more effective and cheaper? So as all of you would know, I don't need to repeat this, but these are stark statistics. 35 million people are visually impaired, 5 million are blind. Despite all this, more than 90% of the blindness can be either prevented or treated. And it is not being done because we do not catch these things. You see all these great videos around of highly complicated cases, but most of them may not reach that stage, diabetic retinopathy being one of the examples, where we get here the proliferative retinopathy cases, which should not reach that stage. Sweden has proven by almost 100% screening of diabetic retinopathy, they have reduced the incidence of blindness due to diabetic retinopathy to zero. There were no cases of blindness due to diabetic retinopathy. So visual impairment obviously affects the quality of life, the productivity, and here more than 2/3 of the population resides in villages and smaller cities, where the availability of ophthalmologists, optometrists are very scarce. So there's a very definite urban-rural disparity, because ophthalmologists like to settle in the cities, and the ratio is 10,000 versus 250,000.
So the access to the villagers and the small city dwellers is not either affordable or they have to travel long distances, and lack of awareness, as was mentioned in the trauma talk. So the geographical barriers, health and education awareness, cost of the equipment, that is one of the main concerns which we are trying to solve. All of you know how expensive the ophthalmic equipments are. And the free screening services are very rare, unlike in the developed world. In the United Kingdom, diabetic retinopathy screening is must and totally free for everybody. Same for school children screening, visual screening. Same for screening during the pregnancy. So there are so many screening services, just like breast screening and other things. There's obvious shortage of optometrists, shortage of ophthalmologists, and the training of the primary care worker is also very poor for them to handle eye equipment. So I know there are lots of leaders in the community care work that is going on, and Arvind Eye Care is mentioned all over the world. Whenever somebody talks about that, they are doing human's duty. Also, you know, the LV Prasad and my alma mater, RP Center. Orbis International, I was involved for a short period of time. They are also doing great work. But what I find is that the visual assessment is still not accurate because we are using these old Snell's charts, and children especially cheat. When you cover one eye, they will look through the other eye, and very difficult for the untrained person to pick up that they are actually cheating. So you miss cases of refractive errors, amblyophias, just because of this chart. So my experience for AI started a long time back when I was working in University of Southern California, Los Angeles. There was a very high incidence of diabetic type 2 diabetes in the what is called the Latino migrants. And they also had challenges of access because they were not insured. And I was the head of retina in the California hospital, where 90% were Latino patients. So again, issues were same as here. Now health education, awareness, and the digital technology had just arrived. In fact, I wrote an article in the local newspaper comparing teleophthalmology to what was happening in Hollywood, because this was the time when they were talking about film, celluloid versus digital, and they were not allowing digital films into Oscars. And now you have Netflix and others competing. So I said same thing is happening here. And we also took benefit of the artificial intelligence. So this was the program I was PI on. This was funded by the California Endowment. It was called Latino Dream, Diabetic Retinopathy Evaluation and Management. And we took these cameras, which were operated by technicians, into the community, primary care, and basically send their pictures onto Doheny Eye Institute. And there we found it very difficult to have ophthalmologists who would look at images because they are busy. They have other things to do, like surgery. So I devised a very, very simple algorithm where we got some school leavers, youngsters who had just come out of school, who started putting in just pattern recognition. They'll say red spots here, yellow spots here, and that was converted into an actual diagnosis of diabetic retinopathy. So this was the first semi-automated screening using kind of AI. So then I've been working on this device. I won't give you any details of this, but this is an AI-powered diagnostic device. I used to call it personal ophthalmic diagnostic system, but now we have developed it onto a second level. Initially was some subjective test, but now we are doing the objective test. So I'll just leave you with this video, and we should be launching this next year. The video is not working. somebody now, whether you need to see somebody in few weeks' time or come back for the screening. And now we also have AI algorithm which can diagnose diabetic retinopathy and AMD. So that's where we are. Hopefully we'll be talking more about this next year. Thank you very much.
Thank you, sir. Thank you. Dr. Hemanti Chaudhary, is she there? Dr. Prachi Grover, please. So this for today's session, Light in the Sea of Darkness, Dr. Prachi Grover.
Good afternoon, everyone. So I'll be presenting a few tips. This is more for the patients. Here are few practical tips for the low vision aid patient like ARMD, advanced glaucoma, Steven-Johnson or RP patients. I just want to mute the volume.
जो गुमशुदा सखाब था वो मिल गया वो खिल गया वो लोहा था पिघल गया खिंचा खिंचा मचल गया
The pictures, actually there were multiple pictures, so I'll tell like for the women with a low vision aids, ask them to do the frying on the back side of the stove, use of the contrast tapes on the tables, on the furnitures, bright lights on the stairs, and install additional lightings in the rooms at home, and use of contrast color tapes and chopping boards can be used in the kitchens. Ask them to carry a strong flashlight at night, and under cabinet lights can be used. Consistently close kitchen and bathroom cabinets or utensils in the accessible areas. Pathway at work areas should be free of extra floor coverings, and clear mark boundaries in home. So these are the two techniques.
जो गुमशुदा सखाब था वो मिल गया.
So this may help the patient to live a life smarter.
Thank you all the speakers. Please come for a group photograph.